About 3 or 4 years ago, I sort of started to take control over my parents' health situation, because they were getting older, and my dad has Parkinson's, and my mom was beginning to find it very challenging to care for him. So I basically started to pay more attention to their medical medical visits, and my husband and I started to also research what we needed to do specifically for elderly care. As part of our discovery, we learned that vaccinations for the elderly was something we needed to pay attention to. Well, I guess my mom comes from a generation where basically they wait for the doctor to tell them what to do. And vaccination is something which I guess maybe the doctors here don't really focus on. And so when I brought up the issue of vaccination, she was kind of suspicious, and said, why do we need this? If I need it, the doctor will tell me. She was quite reluctant at first, and it was only when I found the death certificate of my aunt, who passed away several years before, that we discovered that on the death cert, her cause of death was something quite ordinary, or we thought she had died of something a bit more complex. And it was then that we sort of convinced my mum that very often the elderly, when they go into hospital care, often die not because of what they came in for, but something which develops during the stay. And in this case, it was something which was very much preventable, and it didn't happen for my aunt. So I kind of persuaded my mum with that information that she should allow us to bring her to be vaccinated. Because of my father's medical condition, he gets hospitalized off and on. So one of the things my husband and I were very aware of was how I guess hospitalization itself can lead to complications during your stay. So one of the things which we are very grateful for because of the vaccination is that we never have to really worry that it'll develop into influenza, which might make his recovery a lot more challenging. So we've made it a point to basically all of us to get vaccinated every year. And we're very lucky, I think, that so far it has been very, we've avoided falling sick because of influenza. I always thought that vaccinations were something you gave only to children. And it was only when we started to look at elderly care that we realized, actually, we ourselves actually need to be vaccinated. I didn't realize that actually influenza exists up to today. And what makes it very scary is that it always mutates. There's so many different strains, so you never know how severe you're gonna get when you do get it. So I realized that I was confusing, getting a cold with getting influenza, and I didn't realize that there was actually a difference between the two, even though symptomatically they're very similar. So it was only when I realized that I was confused that we, as a family, realized that we needed to look at vaccination. I would say don't make yourself regret. It's one thing if your loved one, dies of, something, whether it's an accident or, a life-threatening disease. But if it's something which, doesn't cost you very much in terms of money or your time, and can prevent a whole host of other challenges, particularly, when the elderly often have complicated medical developments when they get warded, then I think it's worth taking the time to do it, because it will give you a lot of peace of mind, and it's something you will never regret doing.
Okay. Thanks very much. That gives us some indications of why we are standing here today, starting to talk about what is most important. Older persons account for nearly 90% of flu-related deaths, and WHO estimates that about 1 billion people worldwide get the flu every year. So you can imagine the importance of having your loved ones being vaccinated plays a role, which is what three panelists are going to talk to us today about. But the interesting factor is Southeast Asia estimates to have one of the highest influenza-associated mortality rates, along with South Africa as well, Saharan South Africa. Now, generally, influenza is normally observed in Malaysia as a yearly all-round, but it has changed some way with no definite trends these days. And it's, influenza A is typically reported more often than influenza B, but there can be a significant year-to-year variability. Now, without much ado, I would like to call upon the first speaker, Dr. Irham Ali Haidar Ali, who's a consultant chest physician and head of Department of Respiratory Department Hospital, Pulau Pinang. I've known Irfan for quite a while. Dr. Irfan is a consultant chest physician and head of Department for Respiratory Department at Hospital Hospital Pulau Pinang. And he completed his MBBS in 1998, his postgraduate in medicine in 2005. He's a member of the Respiratory Subspecialty Training Committee and has published numerous articles in relation to papers in relation to national and international journals. And he's going to talk to us this morning about an overview of influenza and COVID-19. Dr. Irfan, please.
Prof. Naden for the kind introduction, and thanks to the organizers for inviting me. So, topic given to me is overview on influenza and COVID-19. I think all of us have heard so much COVID-19, we probably look fed up with it. But anyway, I think we have to go through. I think there's a lot of similarities between both of it. So I'm just going to take you through, but I think my next two colleagues speaking are probably the more important on the vaccinations. So that's the agenda of the day. Let's go to over COVID-19. I think it's all we all know all these facts now. So my slides are not. That's me. How do I? Do I need to press anything? Okay, it's supposed to come out like that, is it? Okay, yeah, that's better. Right, so I'm going through a brief overview on COVID-19 first. So I think we all know the exposure started in 2019 in a place called Wuhan, and it's subsequently spread all across the world. It's with us coming waves after waves, and we do not know when it's going to end. So it just keeps coming and coming. And what is COVID-19? I think we all know what's coronavirus. Now, actually, there are many types of coronavirus. It's been around for so many types. The main three that caused all the problems all these years are the SARS-CoV in 2001, 2002. Then we still have the MERS-CoV lingering around, and then it's the COVID-2. So we do not know what caused the COVID-2, where it came from. So one is probably the cat. MERS-CoV is probably the camel. Third one, I mean, being Malaysians, you all believe in conspiracies, right? So I think it's probably something from the lab. CIA went to Wuhan, all these type of things. Routes of transmission. This was something that I think from the start we all probably, as medical people, would have guessed it's probably airborne from the start. The WHO kept on saying it was respiratory droplets. Halfway, I don't know whether you all follow the news, early in 2020, the chief actually said it was airborne, then actually he changed it to droplets. So it kept on going to and forth. But something that spreads so fast like this has to be airborne. So airborne means it lingers in the air. So it's much faster. So I think we've seen cases where people just cross by each other in the supermarket so they can get exposed to it, which is why the modes of prevention then changes. So airborne, basically it's the same with TB. So for us who have dealt with TB, airborne, the most important thing is just keep all the windows open, get natural ventilation in. Basically, these type of rooms are considered quite dangerous. So, right, the contagious periods keeps on changing. Now, what we practice in Penang GH, I think most KKM hospitals, it depends on your severity of your disease before you can decide they are no longer contagious. For us, that is very important when you decide to switch them from a COVID ward to a non-COVID ward, because you do not want to send a contagious COVID to a non-COVID. And as is new, especially in this current phase, as the case goes up, that's the stress we all face for those of us who manage wards. Beds are so valuable. The minute we suspect they're not contagious, you send them out. Okay. Of course, if you send out too early, then you have outbreaks in your non-COVID wards. So generally, it's category 1, 2, and 3, we take 10 days. 4, 5 is up to 20 days. There is a caveat there. So if you look at up to 20 days, it's up to 20 days plus 24 hours of resolution of symptoms. So that's where it comes a bit tricky. Because most of the COVID actually go on to some degree of post-COVID organizing pneumonia. So they're even breathless up to day 20, day 30, right? So it's by like day 20. After day 20, technically it's safe. But because of the word up to day 20, that comes a bit of a controversy. Okay? So let's say the ward says, I got a category 4, now day 18, I need my bed, I need to send to your ward. Then that's where all the arguments all come in. So this is 9 March, is probably changing faster as we go along now. It's probably spiking very high. The case by age group is because of 18 to 59 is always lumped together as age group, so that will probably be the highest because that's your working crowd. I think we know all this, right? So influenza. So in all this mess, we shouldn't forget influenza. For all of us, we have seen a lot of influenza, and as the case clearly shows, people still die of influenza vaccine. At the start of the pandemic, I think most of us were screening all 3. So when you send your nasal swab, you'll send COVID, flu A, flu B, everything. So we used to get only COVID at that time. After the load got so high, we stopped doing flu A, flu B. So we just do COVID. Okay. So I think influenza is the main thing as part of this conference. Very important is the older people, as what that video showed. I think that video showed very nicely because I like the comment they made where elderly people, that generation, they just believe what the doctors say. Nowadays generation, when it comes to vaccination, what the doctor say, you do the opposite. So that's what's causing a bit of issues here, right? So I think we all know that there's type 1 and type A and type B influenza. It's been circulating around. It always been circulating around. It's endemic. And they come from so many reservoirs, and that's why it's so difficult to completely eradicate. There was a time when the first vaccine came out, we thought we're going to eradicate COVID. One jab, that's it. It doesn't look like it. So the same thing with flu A and flu B. So it's going to keep on coming, especially with climate change and as people start staying closer and closer to wild animals and to livestock. I think we all know the antigenic drift and shift. So it's the shift that is more worrying when they actually change the mutation in a very high level that causes all the pandemics that happen. And the drift is probably the one that causes the annual epidemics, which is why that the vaccine needs to be changed every year. Okay, I think we all know this. All of us have got the flu. I'm sure all of us have got the flu. I'm not sure. I'm sure many of us now have probably got COVID anyway. So you're probably going to be affected one day before. Okay, the highest peak is probably day 1, day 2, day 3, day 4, and then subsequently it goes off. So it's almost same with COVID. If you're talking about category 1 and 2. So this is how the divide. The problem here that we all see is the one day before when we're healthy. So this is why the disease spreads so like wildfire. You can tell the ill people to stay at home, but you won't know one day. And for those of you who have seen COVID patients, it comes very, I'm sure you all have heard colleagues who've got it. One day they're okay, the next day suddenly they're down. It comes very abruptly. For those of you who know, it's seen patients. Even when we had outbreaks among our healthcare workers also, we talking to my staff very well, nicely, and one day, next day don't come to work already. Okay. So this is the surveillance. We've been doing surveillance all across now. A lot of the KKs, they do the surveillance. Hospitals, they do the surveillance. This is WHO one, and you can see nicely in 2020, suddenly flu disappeared. So probably the MCO and all the lockdown does work. I think we know it does work. Like everybody stay at home, nobody gets sick. Okay. So that is you probably get sick of boredom, but you probably healthier. Right? And same thing happened in Malaysia. So from 2020 to 2021, there was practically nothing much lingering around. Okay. December 8, 2021, I still remember that date. That was when they opened the first MCO, they allowed travel. That weekend, I remember I couldn't even go out in Penang. Suddenly everything was so packed, and as expected, then you see the next spike coming in. So impact of influenza and COVID on the older adult population. I think the symptoms are almost the same. It's very hard to differentiate one to the other. Okay? The symptoms are fever, cough, body aches. What differs it from a common cold is normally the more constitutional symptoms, fatigue, vomiting, diarrhea. I mean, all of us who have got viral disease, this is what really puts you off, right? You just feel so drained. The fever, cough, okay, but it's the muscle pain, the muscle ache, so on and so forth. Okay? Transmission, I think I've gone through. And what is very worrying is the mortality. So it's the elderly that have a high amount of mortality, especially those with comorbidities. So this is for COVID. I think you all know that the fatality rate is about 1.06. I think it's probably, I think it probably came down because now the cases are going up. But what we all learned about COVID, that was my bell, is it? Oh, so fast. Okay, sorry. Is that Malaysians are generally a very, very unhealthy population. Right? If you see the number of COVID patients that come in, they are obese, they have so many multiple comorbids, they are just, it increases your mortality rate. So I think we have done probably quite poorly in controlling our comorbids. So 78% of them have at least one underlying health condition. And if you look at influenza, this is what you will see. If you look at the red bar, obviously if you're elderly, the chances of getting hospitalization and death is much higher. I think this one everybody knows. This paper I think was done by my fellow panelists. So I think the same thing in Malaysia, and also the same thing that you apply in Singapore. So I think if you have all these comorbids, and many of our population are this, sometimes when you see an elderly above 60, I think sometimes I always tell my MO, sometimes better ask them what you don't have. If you say sakit apa, they'll tell you diabetic lah, osteoarthritis lah, knee pain lah, hypertension lah, dyslipidemia. Better ask what you don't have, easier to treat. Okay, so the fact that you have 2 or 3 comorbids, then your mortality goes up a lot. Okay, especially if the comorbids are not well controlled. And I think it's always the iceberg story. What we're seeing is probably minimal of what is actually happening in the ground. And what is interesting is this. Influenza is not just a disease of your upper respiratory and your lower respiratory tract. It causes a lot of problems. And we've seen this in COVID. We've seen this in COVID. We've seen people develop diabetes, a lot of cardiovascular complications, even in the post-COVID phase. So I think probably there is some systemic inflammation going on, okay, that causes all these problems. So it's not only the respiratory. And I think the one that we are always worried about is your cardiovascular. So I think you need to tell this to your patients. You may get a mild URTI, but your risk of developing a cardiovascular complication due to that virus is probably going to be quite high, especially if you already have underlying comorbids, right? So I think at this point, we need to stress. And I think this is what we see even in COVID. We see a lot of patients who even category 1 and 2, we have seen quite a few in Penang. Category 1 and 2, that means they're not even admitted. They come back maybe 6 weeks, 8 weeks later with a PE, something like that. Okay, so they get some form of inflammation within the vessels that cause all these issues that happen, that result in AMI or embolism or some thromboembolic phenomenon. So there's something going on there. So it gives us more reason to actually prevent all these viral infections. So how to avoid influenza? I think this one we all know. This is what has been drummed into us for the last 2 years. Cover your nose and mouth with tissue. Wear the mask properly. Stay home when you're sick. Wash your hands often. I think all of us are getting a bit paranoid with that. But I think that's the way to go now. Probably this will be touched by my next 2 speakers, but who they have actually come up with recommendations during this COVID pandemic, who to actually vaccinate. So it's nice to see sometimes when they mention health workers are one of the highest priority in COVID-19. Non-COVID-19 maybe we're not so prioritized. Yes, so the answer to this is definitely yes. We shouldn't lay our guard down. In fact, we should piggyback on the vaccination of COVID. As so many people are talking about vaccination of COVID, we should actually jump on that bandwagon and actually emphasize on influenza vaccination and pneumococcal and whatever vaccination you have not. So I think they both have similar symptoms, and I think we all know the older groups are actually the ones that are more at risk. And so vaccination is probably one of our best weapons that we have for flu and COVID. So with that, I think I would like to thank you all for your attention.
Okay, without much ado, the second speaker is Prof. Tan Maupin. She knows no introduction. I'm sure all of you know her, and all of us in KL know her very well renowned geriatrician. I was going to say pediatrician, but she's geriatrician. And she's one of the backbones of the Malaysian Healthy Aging Society. I'm not going to go through her CV because we all know her very well. And I'm sure you've seen or heard of her sometime or other in the media as well. She's going to talk to us about international and local recommendations on influenza vaccination. Prof. Tan, please.
Thank you, Prof. Nathan. Yeah, my reputation precedes me. Okay. Okay, so I'm known as a person who likes to ask questions. So some of you might know that I actually spent a large proportion of my adult life. In fact, it only equated about 3-4 years ago. I'm still very much as a very young adult in Malaysia, to be honest, because I spent most of my adult life in the UK. And when I came back 10 years ago, I asked this question. When do we give flu vaccines to Malaysians? Because there's no seasons. And unfortunately, like most of the questions I asked, there's no answer. So, but hopefully at the end of this talk, you will be a little bit wiser about what we actually do. Okay, so you all know, that's why we're here today. We're all growing older. Our population is growing older, and it is happening at an unprecedented rate. We're actually talking about multiples. Yeah. So people think maybe 1-2%. No, we're talking about 200%, 300%, those sort of increases. And I mean, it's not here, so we cannot protest. But this was Klang Hospital in 2013. So that was like 10 years ago, nearly. And our hospitals look like that. Yeah. So nowadays they do some sort of management. So it doesn't look like that anymore. But I assure you, inside we are feeling that all the constant pressure that there is never any beds. In fact, we've never had any beds on a geriatric ward for 3 years. We're always 100% full at all times, 102%, sometimes 103% also ada. Yeah, so we park patients in the middle, you know. So the basic problem is that with the population aging, more and more older people are being admitted to hospital, and older people are more likely to need hospital care. Okay, so this is actually a study done 10 years ago in the catchment area of the University of Malaya. So basically, what we found was that when Amin, this is a different Amin, this is a UITM emergency medicine Amin, actually stayed awake for 1 week, didn't sleep, counted every single patient who came through the door in ED, and actually counted 1,000 people. I was like, what? 1,000 people came to ED in 1 week? He went, yeah, bro, that's how busy ED is. Okay, fine. And then it's like, 26% of them were over 60. So, that's crazy. Only 6% of the population is over 60. How come 26% of your ED population is over 60? Something really, really bad about this health service that's not servicing older people, and they're using our ED as a first protocol. But that's not the end of the story. So we look at who ends up being admitted to hospital. Now, if you're young, your chance of getting admitted to hospital is not very high. Okay, so the ones who got admitted are all older people. Yeah. So if you're a young person, 6% chance of being admitted. from ED, if you presented to ED, if you're older, you've got a 50% chance of being admitted. So we end up with more older people in our hospital population. Most of them are over the age of 60. Am I right, doctors? Nurses? Therapists? Most of our patients are now over the age of 60. So let's go back to what our previous speaker actually went on about. So this is COVID. And we know that if you're older, you are more likely to get severe COVID, and you're more likely to die of COVID. But how much more likely? This is actually data from Sungai Buloh, and this 150 times more likely to get severe COVID if you're over the age of 70 compared to if you were of a young adult age group. So that is how much more severe, 150 times. Yeah, not 150%, 150 times, So, and then, in fact, we already knew this. Viral illnesses in older people, bad news. So this was flu figures a couple of decades ago already. If you are older, the older you are, the more likely you are to have influenza-related admissions. Okay, and people used to say, but those cold countries got winter, so this winter flu only comes winter. Malaysia, no winter, no flu lah. That is not true. This is what happens in Malaysia. So this is actually FluNet WHO data, which showed that even pre-pandemic flu used to exist, but we barely ever screen for it. So the way FluNet works is, if they actually randomly survey people with influenza-like illness, and then if they find one, they report to FluNet. But we never did the swab. So how to report? So last time very low, but now with COVID-19, there's an awakening. So even though ultimately flu cases are still down low, we're actually getting more reports of flu than we did pre-pandemic. That's amazing, isn't it? I think COVID has achieved something for us that we have not thought about. Okay, so my previous speaker has already mentioned about the symptoms. Older people present atypically. They do not necessarily have the fever. Instead, they can actually have complications, and they're not necessarily respiratory complications. Okay, so how do we prevent flu? That's really what I'm here to actually share with you today. Okay, so basically, this is something that's causing a lot of hospitalization, actually adding to the already full hospitals that we have, and but it is preventable, and it's cost effective. So, and when we present this to the policymakers, they said, but there's no studies in flu in Malaysia. That's a lie. In fact, we can't do a study on flu vaccination in Malaysia because you cannot randomize to flu vaccine versus no flu vaccine. You cannot withhold the flu vaccine. It's so effective. And this was done a long time ago in Malaysia in a nursing home. And what this actually showed is that, I don't know how they managed to get in 2007 a randomized controlled trial, but they did. They withheld flu vaccination through half of the residents of the nursing home. I don't know how they got the ethics approval, okay? But I'm not about to repeat this study. Okay, so they actually found that the unvaccinated people were more likely to have influenza illnesses, and they were likely to have more influenza illnesses, and the protection actually lasted for over 4 months. So it is actually very effective in reducing hospitalization in nursing home residents. And we all know, all of you know, if you work in a hospital, a large proportion, disproportionately, the patients who actually get admitted to the hospital, older patients who get admitted to hospital are from nursing homes. So we all think all older people live in nursing homes, but that's not true. They're just a particularly frail population who actually are more likely to end up in hospital. So so flu works, and it works most in older people. Sorry, that's 65 and not 54. I still haven't corrected that. It works most in older people. So this is a group we should target. It's just like COVID. You need to vaccinate, but you need to vaccinate the right group. If you vaccinate the wrong group, you end up like Hong Kong. Hong Kong has one of the highest COVID deaths in the world now. Why? Because vaccination uptake in older people is low. So when you want to vaccinate against flu, you have to target the most vulnerable population, and that's the over 65s. Okay. So this is the GOLD guidelines. So GOLD, all of you must know, is actually for lung diseases. So we already have very robust guidelines on people with chronic obstructive pulmonary disease to actually have flu vaccines. Okay. And then So this is some more of the respiratory guidelines. So this is in the CPG, Malaysian CPG, and this also says that they should have, anyone with COPD, with asthma should have flu vaccines. This is actually a compilation of all the other guidelines, and it actually suggests that anyone with heart disease, heart failure, should actually have flu vaccines. And in fact, WHO says HIV as well. So these are what we call the vulnerable groups. And this is the diabetes guidelines. So all these people all say that diabetes people should have flu vaccines. Okay, so basically, anyone who should have flu vaccines, it's pregnant women at any stage of pregnancy, okay, children aged 6 months to 5 years, individuals with chronic medical illnesses, us healthcare workers, as well as older people, anyone over the age of 65, particularly high-risk groups. Okay, so my previous speaker already spoke about the SAGE guidelines recommendations during the COVID-19 pandemic. So the problem is that flu has more or less disappeared during the COVID-19 pandemic. So what do? Do we stop preventing against flu, concentrate on COVID, or do we actually continue to vaccinate against flu? So the concern is that because if we stop vaccinating, we will lose the natural immunity to flu. So when flu comes back, it will be another COVID. So what we really actually recommend is that we should continue vaccinating older people against flu as well, and all the high-risk groups against flu, in hope that when flu does come back after COVID has not gone away but become endemic, then we won't be having a big kind of virulent wave of COVID, of flu. Okay, so this is, so I just share with you the Singapore immunization schedule. Actually recommends flu vaccination for people over the age of 65. Okay, and this is the Malaysian MSIDC, Malaysian Society of Infectious Diseases and Chemotherapy guidelines for adult immunization, and they actually recommend vaccination for anyone over the age of 50. Because apparently Malaysians have a lot of comorbidities, as our previous speaker alluded to, and so it's been recommended that we start at 50. Okay, so and when do we give flu? If in relation to COVID-19? So the Malaysian guidelines currently say separated by 14 days. So preferably if you've had your COVID-19 vaccine, you should wait 2 weeks before you have your flu vaccine, which is not really generally a problem at the moment. But actually this is a CDC guidelines, which actually says we can have it regardless of actual timing. Yeah, so we can have it anytime together, before, after, it doesn't matter. And what we're hoping is when COVID becomes endemic, we are actually giving someone the COVID-19 vaccine and the flu vaccine at the same time at the end of this year. Is that right, Dr. Allen? We want flu and COVID to be given together to older adults at the end of this year. So any policymakers, please listen up. Okay, so with Malaysia, flu happens all year round, as we showed, the graphs we showed you earlier. So there's no good timing. So when is it the best time to have a flu vaccine in Malaysia? Now. Go get it now. Today, make appointment to your doctor, go get your flu vaccine. Okay? So that's the end from me. Thank you.
Do you have to say anything more? Prof. Tan has actually covered it. Go and get your flu vaccine now. The next speaker is Dr. Ellen Jing Swee Hock. He's a consultant geriatrician. I'm sure people in Penang will know him very well. He completed his fellowship training in geriatric medicine at HKL, UMMC, and Tan Tock Seng in Singapore in 2015. He currently heads the geriatric service in Penang. He's the deputy head of the CRC Seberang Jaya Hospital, treasurer of the Malaysian Society for Geriatric Medicine, vice president of the Penang Dementia Association and Postgrad Medical Education Society, and council member of the Fragility Fracture Network of Malaysia. He's contributed numerous articles and guidelines, clinical practice guidelines. He's also one of our scientific committee when we started off this conference in Penang, and he's been very helpful to the Malaysian Healthy Aging Society. Without much ado, I call upon Dr. Allen to talk to us about lessons from COVID-19 vaccination program to increase influenza vaccination awareness and uptake. Thank you.
Thank you very much, Prof. Nathan, for the kind introduction. Today I'm going to talk about the learnings that from COVID-19 vaccination program that we can try to translate into flu vaccination. Right. So before we move to the strategies, I'd like to run through the barriers, why people are vaccine hesitant. Right. Those strategies are actually meant to address one or two or more of the barriers that I'm going to talk about. Okay. First is equity. Vaccines are not equally distributed, especially in under-resourced communities. Cost. Cost is not only monetary terms to our own pocket, to the insurance reimbursement or to the government, but cost also means time and resources, like traveling, time off from work, time off due to recovery from side effects. Access. Travel distance and convenience to vaccination site play a large part in the individual's ability to get vaccinated. The vaccination clinic hours, transportation access, technical skills to search and make an appointment all contribute. Policies. Existing policies such as health insurance requirements, workplace policy influence vaccine uptake. When I was working in Tan Tock Seng Hospital, all the hospital staff are required to take a flu vaccine. And if you opt out, you need to write an explanation letter, a show cause letter, right? So the policy is actually opting out rather than opting in, right? And closely related is inertia. Getting vaccinated takes planning and effort, and the natural tendency is to do nothing, and that leaves people unvaccinated. If a trusted friend or leader in one's community are against getting vaccinated, others will likely follow suit. People may forget to do non-routine activities and procedures if there are no reminders. Okay? If we ask ourselves when was the last time we get our cholesterol checked? Friction. If the process of booking and attending vaccination appointment is too complicated and inconvenient, they will not do it. Misperception. Individuals may have vaccine opinions based on scientific inaccuracies. For example, believing that they are at low risk of getting severely sick, that the pandemic is being exaggerated by politicians, or that vaccines are not effective. There's lack of trust in institutions, including government, big pharma, medical institutions, and the media. Many individuals feel uncertain about the short-term and the long-term side effects, causing them to take cautious wait-and-see approach. Politics. COVID vaccines have been politicized, making political affiliation a strong determinant of vaccination beliefs and behaviors. If your party is against vaccination, very likely you are going to follow that politician. Yeah? Information is not always communicated in ways that reflect social, cultural norms, beliefs, and realities, and this can make information less relevant. Individuals may not fully understand the complex vaccine information being shared, and people are easily confused, especially when new recommendations change frequently. Most misinformation that has circulated about COVID-19 vaccines has focused on vaccine development, safety, and effectiveness, as well as playing down the severity of the pandemic. Some individuals lack the information they need to understand the risks and benefits and make an informed decision. Okay. So what are the strategies that we can use to address one or more of those barriers? First is vaccine ambassadors. If you look around in our daily lives, who are the persons that we can influence? Okay. Because leadership is actually influence. Okay. If you have a lot of influence on that person, you are a leader to that person. Okay. So vaccinated people can become ambassadors to recruit friends and family members to get vaccinated. in one under-resourced community in San Francisco, in the Latin community. So they did this Motivate, Vaccinate, and Activate campaign done together by the community, academic, and the city public health partnership. Okay. The staff encouraged those vaccinated to share their vaccine experiences with the family and friends. And the outcome was, out of those who were fully vaccinated with COVID-19 vaccine, 91% reported that they later recommended to one or more unvaccinated people. 19% reported that they had motivated 6 or more others to get the COVID vaccine. And during the 4-month period, the campaign administered more than 20,000 vaccines in that neighborhood alone. If clinics and hospitals can offer vaccination as a default option during the patient visit, okay, it can increase vaccination rate. In one study, scheduling patients by default increased flu vaccination by 10 percentage points. Okay. Another study showed that patients with standing order receive flu and pneumococcal vaccines significantly more often than those with reminders. Okay. So for hospitals with computerized system, you can try to program it and identify patients and automatically put in the vaccination as a default. Yep. Medical reminders of upcoming vaccination appointments can increase vaccination rate. Okay. In one study in Rochester, New York, showed that when interventions were combined to include patients' reminders, providers' reminders, and telephone outreach, older adults in the intervention group were up to 6 times more likely to get vaccinated against flu. Motivational interviewing refers to patient-centered conversations aimed to support decision-making. Okay. There was one TED Talk about a teenager whose mother didn't allow him to get vaccinated. So in that talk, he said that, my mom is not a monster. Okay? My mom is not a monster. Okay? It is done out of love. Okay? People are vaccine hesitant because they don't have the actual information that they need to make the decision. Okay? So in one study, one project in Pennsylvania, Pittsburgh, 99 pharmacies took part in that project and saw that 33% increase in vaccination over a period of 1 year, okay, by having these patient-centered conversations. Financial incentives. Okay. This refers to providing tangible reward or a chance, like a lottery, okay, at a tangible reward. Okay. So many organizations have done this, including giving grocery gift cards. Amazon, they give like $75 to $500 if you get vaccinated for COVID. Some provide donuts or admission to parks and so forth. Okay. Home delivered. Bringing vaccines to where people are, or home, nursing home, is an effective means to reach hard-to-reach populations. This strategy can be applied to people who are bound to their homes, as well to neighborhoods with low vaccination rates. In many parts of Malaysia, including Penang, we have seen how the public health teams have carried out outreach COVID vaccination in care homes. And the St. John team also offered home-delivered vaccination for people with poor mobility. So this was done by Adventist Hospital. And this Bagan Specialist Hospital, their Joy Luck Club, or what they call it, Just Older Young Club. Okay? School-located vaccination programs are events held in school to remove logistic barriers and increase vaccine rate. Schools are generally easily accessible. People know where they are. They have a lot of ample parking space. Okay. So there's a study looking at the increased success rate in vaccination that has multi-dose regimen. Right? There was one school in Missouri. So Working with partnership with the local pharmacy, the Parkway School District in Missouri vaccinated nearly 3,000 students through their on-site clinic events. Vaccination held on-site at the workplace is also quite successful. Okay? In one study, where flu vaccination rates increased significantly after intervention, 90% of the vaccinated employees received the vaccine at employer-sponsored events. The most important reasons was not because related to health, but the vaccines was free, it was convenient to them, and it would help them avoid being absent from work. Okay. Another survey done at the McKinsey and Company in US found that 83% of those surveyed saying that offering on-site vaccination would increase the likelihood that they will take up COVID vaccine. Vaccine requirements refer to policies that require employees, students, or patrons, like to cafes and cinemas, to be vaccinated and provide proof of vaccination in order to be in compliance. Okay. Insurance policies can mandate vaccination as a requirement for claims in cases of hospitalization, ICU stay, and so forth. Right? That means if you are not vaccinated against flu and you are admitted because of flu, then you are on your own. Right? Houston Medical Methodist was the first healthcare system in the US to mandate COVID vaccination for all employees. And it achieved nearly 100% compliance, with almost 25% of the working staff being vaccinated for COVID. So another 153 employees resigned or were fired for not complying. Then is the effective messages. Effective messages refers to both the messenger and also the messages. The messages have to be tested to prove that it's effective, and the messenger is also very important. One experiment found that if the messages for vaccination is delivered by politicians, it increased resistance to vaccination. so we should be careful also. Provider recommendation refers to healthcare professionals suggesting that the patient receive COVID vaccine. The Advisory Committee on Immunization Practices, ACIP, included this strategy in their recommendation. Last is the combating misinformation. Misinformation refers to sharing of false information, whereas disinformation refers to information that is deliberately misleading and intended to manipulate a narrative. Vaccine myths are particularly difficult to combat, in part because people tend to believe information that is in line with their existing attitudes and worldview. They already made up their mind, so whatever studies or data that comes out is to confirm their biases. Okay. Fact-checking and debunking myths appear to be effective tools to counteract the effects of misinformation, particularly when the correct information sources are universities and health institutions. Everyday social media users can play their own part by correcting misinformation. We are all leaders in our own way, to our family, to our friends, to our aunties, to neighbors, whatever. So we have some influence over them. Okay? While the person originally expressing the misinformation may not be moved, okay, but others who see the correct information can be impacted by it. So responding with empathy and providing facts, rather than simply saying something is wrong, are tips for effective corrections. That's all. Thank you very much.
Could I have the three panelists on stage, please? Dr. Irfan, Prof. Tan. Dr. Allen. Thanks very much. Thanks very much, all three of you. I mean, obviously, the message is so very clear, put through to all of us, simplified, easy and everything. The floor is open now for any questions anyone has got. Has anyone got any questions would you like to ask the panelists? Please feel free, no charge. Okay, since no one has got a question, I would like to start throwing a couple of questions. Maybe Dr. Allen, you could answer this for us. Why is it many people are unaware of the existence of annual influenza vaccination? I mean, if you ask me, a lot of people are not aware. So where are we going wrong, or what is it that's happening?
I think when we talk about people, it includes the healthcare professionals as well. We are partly guilty. You know. Sometimes when we see a patient with so many illnesses, so many diseases, we try to tackle those we think that and prioritize the issues that we want to tackle first. And vaccination is sometimes at the end that we forget.
Prof. Tan, have you got anything on that?
Yeah, there's not enough time in the consultation to actually address everything. And then we're scared to bring it up, right? Because if we say, have you had your flu vaccine? They said no. Then you have to tell them, yes, you can. You should have your flu vaccine, but you have to pay for it. Somewhere you have to tell them where to go to have the flu vaccine, because it's not accessible. So the hesitancy is beyond the individual. If let's say somebody else, like in the COVID vaccine, what has happened now is everybody is asking the patients whether they've had COVID vaccine, so we don't have to spend all that time. We just say, have you had your COVID vaccine? No. Then you straight away refer them to the COVID vaccine nurses who will manage everything. So if we had the same kind of thing going on with flu, it might help.
Now that both of you have mentioned that, you all are so busy in the clinic, and I'm sure Dr. Irfan will agree. Do you think maybe the nurses, the therapists, or the other healthcare professionals can play a role because they spend more time with the patient, the older patient? Dr. Irfan?
Yeah, I think we should try to get everyone in the team to play a part. I think that is very important. In Penang, we're quite fortunate in my department because we have pharmacists, 2 or 3 of them who look at the patient before we actually see them. They counsel more for the inhalation and all that techniques, so on and so forth. But what I think is what the previous speakers alluded to. I think sometimes we ourselves don't actually explain to them what this so-called annual flu. I think we need to get the word across that it is available, and it should be made as easy as possible. So in Penang, if you come now in date, when the budget just comes in now, there's a lot of flu vaccine. So if the patient comes with asthma, what we normally tell them, have you got your flu jab? If they have not got and they are willing, then they get it. If it's readily available, it's just in the next room only. So we actually taken the flu vaccine from the pharmacy to store in our fridge in our TB treatment room to make it very easy. So these are small things that you can do. If you counsel them there and then they agree, you have to catch them there, and then there's a sticker you put on the first cover, flu vaccine given this one. So the next year we will roughly know, around that time, then the next doctor to see there's a sticker there to actually guide them. So these are a few tips that you can do. But I think the awareness needs to be increased.
Prof. Tan, would you say that the yearly vaccinations for elderly, is it cost effective overall?
We are trying to get cost effectiveness data.
And is it covered by medical insurance or?
Unfortunately not. You would have imagined insurance should realize that it is cost effective. But just looking at the actual cost of the influenza vaccine at the moment, if the individual has to go to a private clinic to get it, the cost is actually escalated because it's not it costs the doctor a lot of money to store the vaccine, to manage the vaccine. But if we make it a proper program run by a hospital or even by a primary care setting, actually the whole hospital's budget, you almost need to prevent like one flu, and then it can already be effective. Because from the study that we did in 28% of over 65s actually ended up in hospital, and 10% actually died within 1 year of an index presentation to primary care with flu. That is a scary thing.
That's a scary thing, and obviously, to me, it's cost effective because it saves one's life. That's the most important thing, and many people don't seem to be aware of this. And I'm just wondering whether it's possible to start looking at the inland revenue to look at it as tax claimable, so that becomes an incentive to the people as well. And Prof. Tan, you also mentioned to talk to policymakers. I think three of you have sort of brought that out. And obviously the problem is creating awareness of these sort of things. But the older generation seem to be very skeptical, especially now with the COVID-19 vaccination, isn't it? So to get a yearly shot, when is the best time to get this? Anytime, isn't it, you say? I think it's the best present you could give to your parents on their birthday day. That's the best gift, rather than taking them out for dinner and everything. And I think, as Ellen has mentioned, you know, you could, one of the things, I mean, I'm looking at it this way, it's like renewing a driving license every year. On your birthday, go and renew it. So get your vaccination, so that people have become aware of those things. And one of the other things is, any other organizations could help to market this? Do you think of any international organizations, local market?
I think when you look at certain countries, like pneumonia vaccine started in Hong Kong because of philanthropic funding. Yeah. So what we are considering is potentially getting philanthropists to actually donate vaccines to older people, but ideally it should be part of the national immunization program, which we have already set up because of COVID-19.
And I'm just wondering, did any of these industries, or, I mean, I'm talking about the health professionals associations, ever contact the Rotary Club? They are the best marketers for these sort of things. Rotary Club to promote. I mean, I worked with Rotary. I'm a Rotarian before, and I find that I mean, if you may not be aware, the organ donation, the first setup in KL was done by the Rotary Club. So they play quite a big role. But basically, if you ask me who should be, I mean, I'm going to ask this as the last question, who should be taking an active role in this process? Is it the vaccination industry, Sanofi, or healthcare professionals, or government, or the public?
Everyone.
Exactly. I'm
So
glad that.
When you, it's like the same as COVID-19 vaccine. So they promise that for everyone they vaccinate in their own country, they will also pay for a vaccine for someone in a developing country. So if you, next time you can afford more, you go for your own flu vaccine, maybe you can pay for another 5 people to have their flu vaccine at the same time. And it's an economy of scales. So the more people having the flu vaccine will make it cheaper.
I like Dr. Allen's statement. It's so much of behavioral thing, and very often, Dr. Allen, would you say it won't happen to me? That's the basic thing. Am I right to say that? You know.
Yes, flu is underdiagnosed, underdetected. So, government do not know about the cost of the ICU stay, the acute care, so that they look at the cost of the vaccination. But if we look at prevention actually gives us the highest ROI, the return on investment. If we can prevent one case rather than treating the complications, it would save a lot of cost.
Anyone else got any questions for these 3 panelists? It's incredible what we had today. So obviously, we all need to go and advocate the importance of vaccination for the older people. And I think that's the first step, that we creating awareness. I mean, all of us should play a role one way or the other. It's not the industry of seeing only a geriatrician or the Sanofi or whichever pharma industry it is. So I'd like to thank the 3 speakers. But before we finish, there's a video that's going to be launched. It's just 2 minutes. Please sit down and watch this video. Thank you very much, all 3 panelists. Thank you very much. Just 2 minutes for this video.
Well, I would like to continue enjoying my lifestyle as long as possible. If I can be active independently, both physically and mentally, I will be very happy and very blessed.
Saya nak sihat, tak naklah sakit. Tua-tua ni kalau sakit nanti, terpaksa bergantung kepada orang lain pula.
Nowadays, everything is so expensive lah. My children, they work very hard and I don't want to burden them.
Healthy aging is such an important issue, especially since Malaysia is so well on its way to becoming an aging nation. The COVID-19 pandemic really highlighted us how vulnerable we human beings are to respiratory diseases. But there's another respiratory disease that has been taking the lives of older persons, for decades, namely influenza, or also known in the layman's term as the flu.
Before the COVID-19 pandemic, the flu has taken the lives of approximately 290,000 to 650,000 people every year globally, with most deaths occurring among those 65 years or older. It doesn't help that in Malaysia, majority of older persons live with at least one chronic condition, such as diabetes or heart disease. Catching the flu can worsen their pre-existing disease, and in turn, their disease can also worsen their flu. As a result, they can catch pneumonia, become hospitalized, and develop fatal complications. And for those who recover from a serious flu infection, it may also impair their functional performance to a point where some of them may even need extended care. This is why flu prevention must be prioritized and taken seriously in older persons. One of the most effective ways of preventing the flu is by getting vaccinated annually. I always tell my patients to get vaccinated against the flu because it can prevent severe illnesses, complications, and even death. If you're caring for aged loved ones, you can encourage and support their decisions to get vaccinated so they can be protected against this disease. What's encouraging is that there are caring organizations that have come forward to support flu vaccination for older persons.
I started contacting the clinic kesihatan, our health clinics, each health clinics, and then I surveyed the hospitals in Penang, government and also non-government. I got a lot of help, especially from Dr. Nohasima, the head of the family medicine specialist in Penang. So they quickly organized, and then we determined the doses, and after that, we distributed.
So initially, when Dr. Allen called me about these vaccines, I thought it's very good, and then I asked JKN I want to manage all the things at the primary care site. So I think every one of us should contribute something, especially to our elderly.
Flu vaccination is important for everybody, but it's most important for the older people. So we hope to collaborate with various agencies to promote health among the community in Penang.
A lot more effort needs to be put into public education on the importance of flu vaccine, not just to the elderly, but to their children and the community as well. We do hope that there'll be similar initiatives in the future with like-minded partners.
But in the meantime, let's come together as a society to prioritize flu prevention for older persons, because healthy aging is a right for everyone. Live long, live well.
Thanks, Sanofi, for hosting this lunch symposium. I'm just going to pass over the mic to Mr. Tille. He's got a couple of messages about your lunch.